Shatzkes. I'm actually I'm a trained neuroradiologist, but I am specifically a head and neck radiologist. So that means I really focus my practice on not so much on the brain and spine, but on things like the sinuses, the temporal bones, the neck, soft tissues. But the skull base is an area that is kind of common ground between people who are interested in head and neck topics and people who are interested in brain topics. So neurosurgery, for example, the one area that's sort of relevant to neurosurgery that I do a lot of is pituitary imaging. So I'm going to give you a brief talk about pituitary imaging. And this, again, this is a modification of a talk I do for radiologists. So, if you kind of get lost, please let me know, but I'm going to try to keep this as simple as possible. And luckily, Dr. Steinklein did introduce a couple of things that I am going to talk about. So we're going to look at some anatomy in the region of the sella turcica, which is where the pituitary gland lives. And then we'll look at masses that are native to the pituitary gland. We'll look at suprasellar masses and some parasellar masses. So again, as I mentioned, this is something that lives at the skull base, and specifically the central skull base. So we've got an anterior skull base, a central skull base, and a posterior skull base. And then the temporal bones are actually considered lateral skull base. But what we're talking about today is really centered at the central skull base. And that is really talking about the sphenoid bone, which is one of the most complicated bones in the body. All of these foramina, I think you've heard from Dr. Steinklein before, these cranial nerves come out of these various foramina in the sphenoid bone. But what really we are looking at, the portion of the sphenoid bone that I'm going to concentrate on is the region of the sella turcica, and that is where the pituitary gland lives. So just a little bit of anatomy, and this is a sort of coronal slice. So, slicing off the front of your face and looking straight at you, you're going to see portions of the sphenoid bone. You're going to see a little bit of the sphenoid sinuses. You're going to see these cavernous sinuses, which is where many of the cranial nerves that you heard about live. But in the central portion is the sella turcica. And that is where the pituitary gland lives. So the pituitary gland is a very little gland. It's about the size of a pea, but it's very important for our endocrine function, our hormones, and many of the important glands in the body, such as the thyroid gland, are controlled from the pituitary gland. So the pituitary gland sits in the center of it. It's got a midline stalk. Above it is the optic chiasm, part of our visual tract. And then on either side are these cavernous sinuses, blood-containing venous structures that contain the carotid arteries, as well as a bunch of these cranial nerves. So on a coronal MRI image, and MRI is the primary way that we look at the pituitary gland, we can see sort of mapped out from us the little pituitary gland in red with its stalk, also called the infundibulum. Above it, although it is not really a part of it or related to it, is the optic chiasm, part of our visual pathway. We've got our cavernous sinuses mapped in yellow, and then the carotid arteries, which have a course through the cavernous sinuses, mapped with these orange circles. And these are really the areas that we're going to focus on. So MRI gives us very beautiful anatomy. These are two sagittal images. So if I sliced, half your face off, starting, going sort of through your nose and backwards and looking at you from the side, this is what it would look like on an MRI at the level of the pituitary gland. So this black area is the sphenoid sinus. It contains air. And above it, we see this little gland on this T1 weighted image where CSF in the spaces around the brain is dark. We can see that the gland is kind of an intermediate kind of gray color, except for the back portion, which is very, very bright. And if we go a little bit deeper into this, that little bright spot in the back is really the posterior gland, which is called the neurohypophysis. The anterior part of the gland is called the adenohypophysis, and these secrete different kind of hormones. We look for a normal pituitary bright spot whenever we look at these imaging studies to make sure that that posterior pituitary gland or the neurohypophysis is still there and functioning normally. Now, this image here is another sagittal image, this one with T2 weighting, and T2 weighting gives the CSF all the water surrounding the brain structures. It makes it very white. And it's nice because it can silhouette a lot of these structures. So we can even see a little bit more detail here. Again, the sphenoid sinus is black because it contains air. Air is going to be black on all MRI pulse sequences. And we can see our little gland here. The posterior pituitary looks actually dark instead of bright on this T2 weighted sequence. And we can see a little bit more detail. We can see above it on this sagittal image, the optic chiasm, and that is the place where the input from our different optic nerves kind of join together and then distribute to the different parts of our occipital lobes on either side. Here is that pituitary stalk. This structure here is a part of the hypothalamus, and it's called the tuber cinereum. And then we have this round structure called the mammillary body. And these are all things that we find in this area that's called the suprasellar cistern. It's a cistern because it contains CSF. And again, CSF is white on this sequence. And these are important structures, and all of them can arise can be a source of masses that we will see in this region. So we will revisit these. I did forget to mention that the hormones that were produced by the posterior pituitary or the neurohypophysis are vasopressin and oxytocin. All right, so let's start off by masses that occur actually in the sella. And by far the most common mass to occur in the sella, or really anywhere in this region, is a pituitary adenoma. This is a benign tumor arising from typically the anterior part of the pituitary gland. And it is extremely common. We see it incidentally on scans that we do for other purposes because the patients may be pretty much asymptomatic. And these masses can grow out of the sella from the pituitary gland and present as masses in the suprasellar region above the sella, where we just looked at and we saw the optic chiasm and things like that. But they can also grow laterally into the cavernous sinus region. So when we talk about regional masses, the culprit by far that is the most common is going to be the pituitary adenoma. So because of that, whenever we see a mass in this general region, the first question that we need to ask ourselves is this mass a pituitary adenoma? And a really good way to answer that question is see if we can see normal pituitary gland separate from the mass. And that would mean that the mass is one of the unusual ones that did not arise from pituitary tissue. So if we look at this very large mass in this region, this again is a sagittal view. Here is the pituitary infundibulum. Here's the optic chiasm, but we can't find a normal pituitary gland. And here's our coronal image. And here we can see the optic chiasm. We can see portions of the internal carotid artery, but we don't see a normal pituitary gland. And this is a case of a very large invasive pituitary adenoma. Adenomas, when they get very big, are called macroadenomas. This one has really taken over the whole region. And the pituitary gland is actually the mass. So we don't see a separate mass. This whole thing is really the massively enlarged pituitary gland. All right, so pituitary adenomas are very common. They represent about 10% of tumors within the intracranial compartment, within the region of the brain. So about half of pituitary adenomas will secrete pituitary hormones. And the most common of the hormones to be secreted by a pituitary adenoma is prolactin. So about 50% of pituitary adenomas, these benign tumors, will secrete prolactin. So these often present as patients who are trying to get pregnant, who have infertility issues. The patients often have infertility and galactorrhea, so inappropriate sort of milk leakage from the breasts, and that can be in men or women. So those are common presenting symptoms for pituitary adenoma. The other hormones that are produced by the pituitary gland, like growth hormone, ACTH, which is involved in adrenal function, and TSH, which is thyroid stimulating hormone. These are considerably less common, but they can occur as well. Now, a substantial percentage of pituitary adenomas don't secrete any hormones at all, and they therefore often will be asymptomatic until such time as they grow big enough to cause symptoms because of mass effect. So if we look at this coronal MRI image again, we can see that there is this mass, and this is this area that is darker than the normal pituitary tissue, which will typically vividly enhance. It is growing up, it's growing out of the sella and into the suprasellar cistern, and it is compressing this optic chiasm. These patients will present with visual field cuts because of the mass effect on the optic chiasm. And they also may present with headaches because there is dura that covers the sella called the diaphragma sella. And anytime dura is stretched, it can cause pain. So patients with these non-secretory, also called null cell pituitary adenomas, will present late when these tumors get very big, often with visual field cuts and headaches. So there's really two flavors of pituitary adenomas that we will see, and that as a radiologist, we will image. There are the microadenomas, and those are defined as being less than 1 centimeter in size. So these are often just a couple of millimeters. These will typically be secretory tumors because something this small is not going to present with signs of mass effect. It's typically going to present with signs related to the overproduction of hormone that it secretes. The job of the radiologist in this setting is to actually find these, and you can see that they are very small and they may be very difficult to distinguish from the remainder of the gland. So after contrast administration, we give gadolinium when we do MR imaging, some form of gadolinium. The gland will enhance, the cavernous sinuses with their blood pool will enhance, and microadenomas or macroadenomas will also enhance, but they enhance to a lesser extent and often later than the normal pituitary tissue. So detecting them can be very difficult. And we work really, really hard to optimize our MR scanning technique. We want to get very thin sections, and we want to make sure that we scan in time to see the pituitary adenoma distinct from the gland. On the other hand, picking up macroadenomas is not an eye test. These are going to be big, greater than a centimeter. So detection is really not the issue. The issue has a lot more to do with mapping them. Where are they going? Are they growing upwards like this one and smashing the optic chiasm? Are they growing laterally and invading the cavernous sinuses? And as we'll see in a second, that is really important for surgical planning and something we spend some time doing. So this is a patient with Cushing syndrome. So this patient presented with a hormonal disturbance. And, you know, we're looking at the pituitary gland. These are two coronal images. Here's our optic chiasm. Here's our gland. And certainly the gland is not enlarged. So we know we're not going to be dealing with a macroadenoma. And in fact, this little focus over here represented this patient's microadenoma. So these ACTH secreting pituitary adenomas are notoriously difficult to see. They may be very, very small, and they often have signal characteristics that make them very difficult to distinguish from normal pituitary tissue. So that is one of the great challenges that we have in imaging for microadenomas. Now, pituitary macroadenomas, again, by definition, they're a centimeter or less. They are actually quite a bit less common than the little tumors. So they often have a interesting characteristic sort of snowman or dumbbell appearance because, as I mentioned, there is a dural covering of the sella. And when pituitary macroadenomas grow out of the sella and into the suprasellar cistern, they often get cinched at the waist by the residual portion of the diaphragma sella, that dura. So they have this sort of snowman appearance. You can see this really big macroadenoma. It's growing out. You can see it's compressing the optic chiasm. That's why these patients present with visual symptoms. Now, when these grow very big, they can outstrip their blood supply. And as this graphic is kind of showing you, they may have cystic components because the tissue sort of breaks down, or they may even have hemorrhagic components, and sometimes hemorrhage into a macroadenoma can be kind of a very dramatic cause of quick vision loss and severe headache. So here's an MRI image of a macroadenoma. This is actually a T2 weighted image. We know because the CSF around the brain is bright, and actually in the ventricles is bright. This macroadenoma is growing out of the sella turcica. Here's the diaphragma sella, that dura, and you can see again this sort of like snowman kind of shape. This one is kind of spilling out laterally and growing even further. These are the internal carotid arteries. They look like areas of no signal on this sequence because of the rapidly flowing blood. So looking to see whether a macroadenoma has invaded the cavernous sinus is a very challenging thing that we do. So if we look at this macroadenoma, here's the normal pituitary tissue enhancing normally. Here's a very big area of diminished enhancement in the left side of the gland. And here's our internal carotid arteries. This is the cavernous segment, and this is the suprasellar segment. And we can see that there is tumor that is heading out there, and that is tumor that's heading out towards the cavernous sinus. Tumor can kind of press the cavernous sinus, can have mass effect and efface it. But what we really want to be able to tell the neurosurgeon is whether or not the tumor has invaded the cavernous sinus. And there's a few tricks that we will do to try to make that determination. So if the carotid artery is encased by more than 2/3 by the tumor, that's a sign of cavernous sinus invasion. If we look at this one, it's about 180 degrees, so maybe half encased, not fully. So we don't have that criterion. But we can draw these different lines, and these are lines that we draw between the cavernous and the suprasellar segments. Again, this is shown graphically. This is the suprasellar one. This is the cavernous ICA. We can draw medial, median, and lateral lines, but the only one that's important is the lateral line, because if the tumor passes that lateral line, that's a good sign that there is likely cavernous sinus invasion. So if we draw that on this image, we can see that here's our lateral intercarotid line, and the tumor has surpassed it. This means there is likely cavernous sinus extension. We can also look for invasion of certain segments of the cavernous sinus itself, particularly this carotid sulcus venous compartment. But these are the kind of things that we need to look for when we are mapping macroadenomas. So I mentioned that sometimes these tumors can outstrip their blood supply, developing cysts, but what can sometimes happen is a sudden hemorrhage into a pituitary macroadenoma that can cause massive and sudden enlargement of the macroadenoma, and that can cause acute visual changes. The patients may have a severe headache. They may present with vomiting. This is often in the postpartum setting, in which case it's called Cushing Syndrome, but may also occur in the setting of patients who are being treated medically for a pituitary adenoma. That sets them up for potential hemorrhage into the adenoma, also called pituitary apoplexy. What we see is odd signal. We will see a pituitary adenoma. This is a scan without contrast on that T1 weighted image. And here's our little pituitary bright spot back there, but the rest of the gland should be pretty much the same signal as the brain. This one way too bright, this one massively enlarged, and also, abnormal signal, definitely brighter than the brain. Both of these are patients who bled into their macroadenomas, causing pituitary apoplexy. That's the optic chiasm. Look how it is stretched along the superior surface of this massively enlarged hemorrhagic gland. So again, these can grow extremely big, particularly when they don't secrete hormones. And this is another case of an invasive pituitary macroadenoma. Look how massive this is. Again, there is no normal pituitary tissue here. There's a huge mass, which is growing into the nasal cavity and destroying the whole sphenoid bone, as well as a portion of the clivus. All represent an invasive pituitary macroadenoma. Now, again, these are actually benign tumors, but they can cause a whole lot of bone destruction and a whole lot of growth. Another interesting intrasellar lesion, which is extremely common and present incidentally on a lot of imaging studies, is the Rathke's cleft cyst. So this is a congenital non-tumor remnant of an embryologic structure called Rathke's pouch that lives in the region. So these are little, typically cysts, and they occur in the midline portion, either in the gland itself or sometimes in the suprasellar cistern. And because they are cysts and just contain, not solid material, they don't enhance, but they can have unusual signal characteristics. This is a pre-contrast image. We might think that this is the posterior pituitary gland because it's this little bright spot, but we are actually more anterior than would be expected. This little round thing is sort of bright without contrast. If you just looked at this post-contrast image, you might think that this is a pituitary adenoma because it's enhancing less than the normal pituitary gland. You really need to check the pre-contrast image to see that this is not actually enhancement. There's just this bright signal that's living there in general. And this is very typical T2 bright appearance of a cyst. Now, there is an interesting little feature that can really cement the diagnosis that something is a Rathke's cleft cyst, in that they often have these little nodules in them. Here is a larger Rathke's cleft cyst. This one not fully T1 bright, but you see this little kind of nodule in it. The cyst does not enhance after we give contrast, and we don't expect it to because it's a cyst. And here on the T2 weighted image, you can see it almost looks like a sunny side up egg. This is the actual cyst. This is this little nodule. And when you see that, you are looking at a Rathke's cleft cyst. These are benign, not tumor. Here's a collection that I have of these little waxy nodules in different lesions, all Rathke's cleft cyst. This one's a little white dot. This one's a little black dot. It's just a cyst with a little dot is almost always a Rathke's cleft cyst. All right, well, let's see how we are time-wise. We'll kind of do just, I know everything's a bit behind. I will try to finish up by 12:15. So Suprasellar masses, we'll go through these quickly, and we've already done a lot of the work because, as I mentioned, most of the masses that occur in this region, whether it's intrasellar, suprasellar, or parasellar, are pituitary macroadenomas, which we've already discussed. But the other kind of structures that live in that suprasellar cistern can give rise to other masses besides pituitary adenomas. So we know that the optic chiasm lives there, the hypothalamus, the tuber cinereum, and the mammillary bodies live there. The stalk of the pituitary gland lives there, and there's also dura covering the diaphragma sella, and also covering the bony components of the sella turcica. So these are going to give rise to some of these other structures that we will see in the suprasellar cistern. Now, there is a differential diagnosis for suprasellar masses by age, which is different in adults. Pituitary macroadenoma is by far the most common suprasellar mass, followed by meningiomas, the most common quote unquote brain tumor overall, but there's meninges around there. So but that is a disease of adults typically. And then aneurysms related to the carotid artery, which lives right there. And in the pediatric age group, we've got different lesions related more to the other structures that live in that location. So craniopharyngioma is a very common suprasellar mass that can even arise within the sella, mostly in children. So this is another remnant of Rathke's pouch, just like the Rathke's cleft cyst. However, this is actually a tumor. It's a neoplasm. It is histologically a benign tumor. However, it can be very locally aggressive and cause a lot of morbidity because it does have a tendency to invade and be adherent to these adjacent structures. So complete resection may be very difficult. Recurrence can be very common. The interesting things about these tumors on imaging is that they can just sort of look like anything. They are often very bizarre looking. This is a CT image, and we can see a low density structure that looks like a cyst with all sorts of coarse calcification around its periphery in the suprasellar cistern. This is an MRI image. Portions of this are really not enhancing. Portions of it are enhancing like little nodules. So these are, again, different, very bizarre looking craniopharyngiomas in children. This is another CT image. Look at that bizarre coarse calcification. The combination of cysts and calcification should make you think of craniopharyngioma, especially in children. This one with on an MRI has a lot of nodular enhancement, a big old cyst pushing superiorly. This one kind of looks like a snowman, but really a cystic looking snowman. So there are different varieties of craniopharyngiomas, but this very heterogeneous looking one is called an adamantinomatous variant, and that's what we see typically in children. We can have tumors that are primary to the optic chiasm, and those will typically be gliomas, just like we see in the brain tissue, because the optic nerve and the optic chiasm is really brain. They're not actually nerves. They're not composed of Schwann cells like nerves are. So these occur in children and adults. Luckily, in children, they tend to be relatively benign variants. In adults, they tend to be very aggressive variants, essentially like glioblastoma multiforme. So this is an adult with an enhancing glioblastoma multiforme of the optic chiasm. This child has a non-enhancing optic glioma, which was a pilocytic or benign variant, and these can be associated with neurofibromatosis. Hypothalamic hamartomas are very interesting lesions. So these are also not tumors. They arise from the hypothalamus. So remember that the hypothalamus lives in the suprasellar cistern. This is that round mammillary body, and this is the tuber cinereum. Those are hypothalamic structures. So this hamartoma can arise from that portion of the hypothalamus. So these, again, are not tumor. They are essentially gray matter of the brain living where gray matter should not live. So really, the signal within these lesions follows that of brain elsewhere. They don't enhance. They're not, neoplastic in any way. And they present with a really interesting clinical syndrome of, they typically present in children with precocious puberty and or gelastic seizures, which are seizures characterized by uncontrollable laughing. So a very characteristic and interesting clinical syndrome, and an interesting little lesion that is not actually a tumor that occurs in this location. Now, remember we talked about the normal pituitary bright spot, which is supposed to live in the back of the sella. Sometimes that neurohypophysis, that posterior pituitary bright spot, never makes it down there, and it gets arrested in the suprasellar cistern. So we may end up with a little round bright spot above the pituitary gland instead of on that posterior margin. So that's called an ectopic neurohypophysis, which is kind of an easily recognizable sort of congenital variant. Sometimes it may reflect trauma because of transection of the infundibulum in the setting of really severe kind of shearing trauma. All right, so we will finish up the last minute or so with parasellar masses. We've already talked about many of these. Again, pituitary macroadenoma growing into the cavernous sinus is the most common cause of a parasellar mass. But we have to add a few things here, and we're not going to talk about all of them, but we do want to focus on aneurysms, because that is something that is a diagnosis we definitely want to make before a surgeon plans on going in there. So dilatation of the internal carotid artery segments that are near the sella turcica can result in masses in this location. And unless you recognize them as an aneurysm, this can lead to, catastrophe. So most pituitary surgery is done through an endoscope, through the nose, through the sphenoid sinus, and down through the sella floor to resect a pituitary tumor. But if there is an adjacent aneurysm, or if the tumor is actually an aneurysm, you are left with a potential catastrophic situation where there's a breach of an aneurysm wall with a lot of difficulty in controlling bleeding when you are dealing with just an endoscope. So it's worth taking a second, and we do this as radiologists all the time, to consider whether any sellar region mass might possibly be an aneurysm. And usually you can quickly say no, but sometimes that can be, harder to do. So here are two MRI images. This is a T1 scan with contrast, and this is a T2 scan. And we see that there is a right parasellar mass. Here are the sphenoid sinuses. And it looks like it is an enhancing mass. So, we're kind of wondering, what could this be? We haven't really looked at the pituitary gland yet, but we'll consider whether it's, a macroadenoma that's growing out. It has some weird signal on the T2 weighted image. Again, here our CSF is white, so we know we're looking at a T2 weighted image. It's super black. It is really, really black. And that should sort of give us pause. And the radiologist who looked at this was, concerned enough about this, because one of the things that gives you blackness on a T2 weighted image is very fast blood flow. So the radiologist suggested that they do an MRA, and a magnetic resonance angiogram. And this is the normal left internal carotid artery. This is the basilar artery, and this is a big aneurysm of the pre-cavernous segment of the internal carotid artery. So this was the appearance of an aneurysm, looking like a sort of innocuous parasellar mass. Here it is on a nice 3D rendering showing you the appearance of that big ICA aneurysm. Sometimes the internal carotid arteries can actually live in the sella. So this ICA is within the pituitary tissue in this patient. They're both living in there, definitely on our checklist of something we want to warn the surgeons about if they are planning to enter that area through an endoscope. Meningiomas can occur anywhere there's dura, and there's certainly a whole lot of dura in and around the sella turcica. This is a parasellar meningioma. These will typically invade the cavernous sinus. Again, these are the most common brain tumor, brain in quotes, because they are not tumors of the brain. They arise from the meninges. But this very big one is filling the cavernous sinus, surrounding the internal carotid artery, growing actually into the posterior fossa and compressing the trigeminal nerve you heard about previously, a pretty common location. This a very massive schwannoma of one of the cranial nerves, typically from the trigeminal nerve, living in the cavernous sinus and growing into the sella turcica, as well as growing through foramen ovale into the space below the skull base. This is a very pretty schwannoma of cranial nerve 3. This is a coronal image. Here's our pituitary gland, our cavernous sinus. This is the normal cranial nerve 3. This one has been replaced by an enhancing mass, and it's actually the absence of this little filling defect that is the pathology. So that is a schwannoma of cranial nerve 3. And finally, this is a chordoma, a tumor that can arise sort of anywhere around the central skull base. This one is actually growing into the cavernous sinus and into the sella, pushing the normal pituitary gland to the side. Okay, so some points to remember. Pituitary adenoma is by far the most common sellar region mass. So, any mass in the sella turcica, above it in the suprasellar system, or lateral to it can certainly be, and most likely is, a pituitary adenoma. A good first step in whenever you see a regional mass is to find the normal pituitary gland, because if you can't, the mass may actually be the pituitary gland. Microadenomas are very small. Our challenge on imaging is to actually find them, whereas macroadenomas are big, more than a centimeter, and we want to look and see what they do to the adjacent structures. Is it compressing the optic chiasm? Is it growing into the cavernous sinus? And then finally, to be safe, we want to consider the possibility of an aneurysm for any mass in this region.